Welcome everyone to the CMS Digital Quality Measure DQM public comment webinar. Thank you for joining us today. We appreciate your participation and feedback as we advance digital quality measurement. Just some housekeeping items. This session is being recorded. The recording will be available to attendees after the webinar if you are joining via the Teams app. The slides are currently available on the ECQI Resource Center website, and a link will be provided in the Q&A window. A recording will be available on the site following review. We encourage you to submit questions throughout the presentation using the Q&A panel. For a better experience, please download the Teams app to be able to contribute questions directly. To access the Q&A, click the Q&A icon, the speech bubble with a question mark, in the top right of your Teams window. Select Ask a Question, type in your question, and click Send. You can also view other questions and upvote those you find relevant. We will address as many questions as possible during the Q&A session at the end of the presentation. Today's session will walk through the purpose, goals, and key considerations for reviewing DQM materials. Instructions for submitting formal public comments will be provided later in the presentation. Next slide, please. During this session, we will discuss the purpose and goals for the presentation, review the transition to digital quality measurement, including advancing quality measures throughout the use of FHIR, FHIR benefits and overview, FHIR as it applies to quality measures. We will then review the contents of the FHIR public comment period published through the MADIE tool, including measure packages and new test case exports that are available for your review. Next slide, please. Additionally, we will review DQM components, hypoglycemia measures representing a new area of collaboration between CMS and CDC, and the DQM public comment process. We are pleased to welcome Joel Andress, the Digital Quality Measurement Lead at CMS. Joel leads efforts to move CMS quality measurement into digital formats, reducing reporting burden for care providers and advancing healthcare data interoperability. Next, I'll pass it to Joel from CMS to begin the presentation. Thank you.
Thank you, Amira, and greetings everyone, and welcome to our presentation today. We've asked you to join us to take a forward-looking view of the future of quality reporting across CMS's programs and highlight how CMS is modernizing quality measurement through its digital quality measures. We're hoping to set expectations for upcoming changes in how quality measures are developed, implemented, and reported across our programs, and to give you an opportunity to actively participate in that transition. CMS has been moving forward toward a digital-first quality measurement strategy with an emphasis on interoperability, automation, reduced provider burden, improved data accuracy, and timeliness. Digital quality measures enable alignment between clinical care, reporting requirements, and program accountability that have long been sought in CMS quality programs. And our belief is that by implementing digital quality measures, we'll be able to support the long-term sustainability of these programs and greater improvement in the quality of care in our provider systems. The primary purpose of this presentation is to present to you what we're going to be doing during the DQM public comment period that's beginning today, and to clarify for you how you can meaningfully engage with us during that period to review what we're posting for the digital quality measures, as well as point you in a direction of the kinds of feedback that we're looking to obtain during this discussion. As always, we encourage your active participation, and your input is certainly welcome. CMS programs are currently transitioning from traditional measures to FHIR-based digital quality measures. These changes may include updated measure logic, new data requirements, and enhanced technical specifications, and are designed to improve measure validity, increase the interoperability of the data being collected, and support automated reporting within CMS's programs. We are seeking to ensure that there is an alignment between human readable and computable specifications that we've developed in the FHIR standard, ensure that there's a feasibility of collecting required data elements in EHR systems, and try to get a sense of what the potential impact on reporting workflows and provider burden would be given the changes to these measures. To facilitate your feedback, we have prepared ONC JIRA tickets in our system in order to house the measure specifications and select test decks. After review, comments may be submitted directly to the corresponding measure ticket, where the measure steward and developer will review and respond following the close of the public comment period. Our hope is that this will provide us an opportunity to obtain clear insight into the transition of digital quality measurement, equip all of you with the context needed to understand what we're changing about these measures and the presentation of information regarding them, and to enable meaningful stakeholder participation in the development and implementation process. As an outcome of this discussion, we hope to ensure that you understand the direction of the CMS quality reporting and are able to review the digital quality measure artifacts that we're presenting, interpret technical and human readable components, and provide informed, constructive feedback. CMS is currently in the process of converting its electronic clinical quality measures into digital quality measures that are based on the FHIR standard. These converted measures will ultimately represent a subset of digital quality measures that will be a much more expansive category and incorporate other sources of data and reporting. While related, digital quality measures are distinct from the current program ECQMs and are built on a different data model and technical foundation. ECQMs have been used for many years across the CMS quality reporting programs. They're based on the quality data model, or QDM, which is defined specifically for CMS use and designed primarily for reporting from electronic health records. ECQMs have enabled automated reporting compared to manual abstraction, but are limited in their interoperability and are closely tied to EHR-based data sources. Digital quality measures, on the other hand, are built on FHIR standard and use interoperable data. They use that as an interoperable data model, designed to be modular, reusable, and scalable across programs and use cases. The measures can include data requirements that are not confined to a single system. Digital quality measures expand the concept of data sources to include medical devices, clinical systems, patient-facing applications, and other digital health technologies beyond traditional EHRs. Converting ECQMs to DQMs preserves existing measure intent while modernizing the technical foundation, and that positions CMS quality programs for greater interoperability, reduced reporting burden, and more comprehensive and timely quality insights. FHIR, as many of you are aware, is a data standard from HL7 and defines how healthcare information can be exchanged between different computer systems regardless of how it is stored in those systems. It allows healthcare information, including clinical administrative data, to be available securely to those who have the need to access it and to those who have the right to do so for the benefit of patients receiving care. FHIR provides a comprehensive framework for implementing clinical quality measures and offers a standardized set of resources and operations that support the representation, sharing, and evaluation of clinical knowledge artifacts. Additionally, it's not constrained simply to the quality measurement purpose, and this means that the data are interoperable for a variety of purposes, not simply within our reporting programs. The framework enables standardization and interoperability by using consistent data formats and structures and facilitating seamless integration across the diverse healthcare systems. Automation and real-time access are facilitated through data exchange and supported by real-time retrieval and evaluation of clinical data. FHIR uses structured data in order to enhance accuracy and enable more informed decision-making and timely interventions. The modular design and RESTful APIs support rapid implementation, scalability, and adaptability to the evolving requirements. Data collected for the purpose of our program are then reusable for different purposes, increasing the efficiency of the data collection. FHIR supports efficient handling of large data sets and enables population-level analysis and reporting. So what are FHIR resources? In FHIR, healthcare data are broken down into categories such as patients, encounters, medications, and so on. Each of these categories are represented by a FHIR resource, which includes its data elements, constraints on data, and relationships. These resources are designed for reuse, performance, usability, fidelity, and implementability. So what does that mean? It means that they're designed to meet general needs of healthcare to avoid overcomplicated, redundant resource sets. where we're capturing different versions of the same piece of data in many different ways. It improves on performance in constructions, making these better suited for being exchanged across data networks. It's designed to be understood by technical experts and non-technical people alike, and it's designed to restrict intermixing of values with differing data types. Again, these are easy to understand, readily exchanged using industry standards, common programming languages, and established data exchange technologies, which improves on the implementability. Currently, there are 157 resources in FHIR, and the next slide includes some common resources in use with our digital quality measures included in this public comment period. The clinical module includes allergy intolerance, condition problems, procedure, and care plans resources. Some resources may reference other resources such as service requests. The diagnostics module includes observation and diagnostic report. For more information on FHIR modules, check out the FHIR R4 homepage at HL7. Base FHIR resources are intentionally generic by design to support broad reuse, flexibility, and interoperability across many healthcare uses. Because base resources are generic, FHIR relies on profiles and implementation guides to add specificity for particular needs, such as CMS programs or digital quality measures, while maintaining a common interoperable foundation. A FHIR profile is a set of rules and constraints applied to a FHIR resource to define how that resource must be used for a specific use case. In other words, a profile takes a general FHIR resource and tailors it for a particular purpose, such as quality measurement, reporting, or a specific CMS program. It's important to know that a FHIR profile will constrain a base resource by requiring or prohibiting certain elements, specifying value sets or code systems, and setting directionality of the element and how many times the element can appear. It ensures consistency across implementations and supports interoperability by clearly defining the expectations for the collected data. A FHIR implementation guide, on the other hand, is a document or a digital resource that provides detailed instructions for using FHIR in a specific context, program, or use case. Think of it as a recipe book that tells implementers exactly how to apply FHIR standards correctly. The contents of an implementation guide include profiles, extensions, value set bindings, examples and sample data, rules and constraints, and guidance for implementers. The QI Core Implementation Guide is a FHIR-based implementation guide developed to standardize how clinical data are represented for quality measurement and improvement. It provides a bridge between clinical care data and digital quality measures. This IG ensures consistent and interoperable representation of clinical concepts needed for quality measurement, facilitates the transition from traditional ECQMs based on the QDM to FHIR-based digital quality measures, and supports quality reporting programs, clinical decision support, and population health initiatives. In a nutshell, the QI Core IG is a foundational guide that defines how clinical data should be represented in FHIR so that quality measures can be accurate, interoperable, and implementable. Other IGs that are key to the implementation of measures include the Quality Measure IG or QMIG, which essentially defines how a measure is constructed, and the DEQM or Data Exchange for Quality Measures IG, which defines how to exchange digital quality measurement data between systems, i.e., how to report the measures to CMS when it's time to do so. This slide provides an illustration of the transition from the current ECQM approach and their related implementation guides to a FHIR-based DQM approach. Current ECQMs rely on the quality data model, as CQL for measure logic, the CQL-based HQMF for measure definition, and the QRDA 1 and 3 for measure reporting. FHIR-based approach for DQMs replaces these with the QI Core FHIR profiles for use as the data model, retains the CQL logic standard, and incorporates FHIR measure resources for measure definition and the DEQM individual and summary for measure reporting. Overall, this is intended to emphasize a modernization for FHIR standards, reducing reliance on QDM and QRDA while retaining CQL and improving the interoperability and consistency across measure definition and reporting. And notably, also including consistency with non-quality measure uses of these data. This table represents a mapping between QDM data types and FHIR QI core profiles for digital quality measures. It shows how each clinical concept in QDM translates to a FHIR resource and the conditions needed for it to count in a measure. And this is gives you some idea of the kind of mapping we've undertaken as we've converted our measures into the FHIR standard. You can find more information about the mapping if you check out the quality data model, QDM version 5.6 to QI Core R6 mapping part of the QI Core IG on HL7. On this slide, we can see CQL with QDM versus QI Core and how they interact. The graphic displays the QDM version of the initial population translated to the QI Core version on the bottom half of the slide. Both definitions identify adults ages 18 to 75 who had at least one qualifying encounter and have a diagnosis of diabetes during the measurement period. And the QDM version uses a diagnosis data element and checks whether the diabetes diagnosis prevalence period overlaps any day of the measurement period. On the other hand, the QI Core version uses condition encounter diagnosis, which is a FHIR-based resource, and requires the condition to be verified and checks whether the diabetes condition's prevalence interval overlaps any day of the measurement period. In short, the clinical intent is the same in both models. The difference is that QI Core expresses the logic using FHIR QI Core constructs and functions, such as verified conditions and prevalence interval, whereas QDM uses QDM-specific data elements and attributes. So all of that's well and good, but then we come to the question of how we are able to represent this information to you to support your implementation of it as stakeholders. And that's where MADIE comes in. MADIE is a second-generation tool that's designed for the creation, testing, and management of both ECQMs and digital quality measures. It essentially takes on the role of the MAT and BONI tools in combination. And is able to incorporate both QDM and FHIR data models for use in measure publication. It provides a web-based interface where users, such as measure developers and healthcare professionals, can author measures using standardized languages such as CQL to execute measure logic against the constructed test cases to provide users with information to evaluate whether or not the measure logic aligns with the intent of the measure. In short, MADIE streamlines the development, testing, and management of quality measures to improve healthcare reporting outcomes. MADIE's role is also to publish the artifacts that are there for you to assist you in the implementation of these measures. And so much of what you'll be reviewing in the public comment beginning today comes from the MADIE system. As part of the measure authorship process, MADIE publishes a number of digital quality measure exports that are essentially the different ways a measure and its related components can be saved or shared. Each format serves a specific purpose. So the measure hypertext markup language, HTML, is a human readable web page version of the measure. It's useful for viewing the measure in a browser or sharing it with people who don't need to read the raw code. This essentially is what allows you to take a look at it and know what the measure is about as a subject matter expert or clinician or a measure expert. The JSON notation is a machine readable format. It stores the measure in a structured way that software systems can parse, process, or import. And then the XML format is another machine readable format that's widely used in healthcare IT and represents the measure in a standardized structure compatible with digital systems. In addition to these three formats of the measure specifications, we provide the CQL folder, which contains the clinical quality language files, including the measure CQL, which is the main CQL code the user wrote for the measure. The CQL for all included libraries incorporates any additional CQL libraries the measure depends on, like reusable functions or definitions, which are critical for computable logic, the instructions that tell software how to calculate the measure. The resource folder contains supporting files for included libraries. The JSON file for all included libraries incorporates machine-readable JSON versions of any libraries in use. The XML file for all included libraries provides XML versions of those same libraries. And these ensure that all referenced libraries are included so the measure can run correctly in other systems. To summarize, MADIE exports measures in multiple formats: HTML for humans, JSON and XML for machines, and CQL folders for the measure logic and supporting libraries so they can be viewed, shared, and implemented consistently. Under the DQM public comment, CMS is publishing the DQM measure packages for those measures we've converted to the FHIR standard. The publication of these packages containing these files that I've described includes what we believe to be an appropriate representation of the artifacts that would publish in future annual updates for those DQMs. So essentially, we're presenting to you what we think measure packages would look like once we implemented FHIR digital quality measurement reporting. This slide provides you with a snapshot of the human readable header or metadata that comes along with the digital quality measure. This is essentially the front page or metadata summary of a quality measure in the digital format. It provides key information about the measure that systems, users, and developers need to understand it without reading the full measure logic. It functions as something as a label on a book. It tells you the title, author, and what the book is about before you dive in. The DQM header is important because it travels with the measure when exporting, sharing, or implementing it in health IT systems. It allows software to quickly identify and categorize the measure without parsing all of its logic. This is a snapshot of the human readable body, which is similar in appearance to the QDM body. The header and body are also referred to as measure specifications, particularly in quality measurement circles. A digital quality measure body is essentially the core logic of a digital quality measure, the part that tells software how to actually calculate or evaluate the measure. If the header is like the label on a book, the body is like the content inside. The DQM body usually includes measure logic and definitions, which incorporate the actual criteria, calculations, and rules used to determine if patients meet the measure. It's written in CQL or another computable format. The populations field specifies the denominator and numerator who meet for the measure, and may also include exclusions, exceptions, or stratifications used within the measure. Functions and expressions can provide reusable code snippets or calculations used within the measure, and can be included and can include libraries that provide shared logic for the measure. The patient data fields the measure uses and FHIR resources can also be referenced in the body, and any additional execution instructions can be incorporated within the body to provide assistance in implementation. Here you can see a side-by-side comparison of the metadata for ECQMs and DQMs. Some of the fields are renamed. A handful that were obsolete, such as the transmission format, were removed, and other concepts have been revised to fit with FHIR data standard and its requirements. But by and large, what you're going to see is comparable to what you've seen before and involves an updating of the format to match with what is provided under the FHIR standard. So the focus of this is to give you an opportunity to see how we've mapped out these measures, what they look like, and provide us feedback. We also want to hear about any ambiguities in how we've presented the materials, whether or not if something's missing that would be important to include, or if something is presented in a way that's difficult to use. This is an opportunity for you to call that out and provide us with feedback so we can consider how best to ensure that the documentation we provide in the future meets the needs of the stakeholder community. Something that's new to what we're posting here are the test case exports. We haven't posted these in the past, but we've had interest in looking at them. We think that sort of shifting over to the FHIR standard gives us an opportunity to do so fairly cleanly. And so we're piloting 4 test decks for 4 measures as part of this public comment period to get your feedback on the presentation and usability of the test decks and get your feedback. And because we haven't posted these before, we haven't received feedback on them before, so we're particularly interested in seeing what, if anything, needs to be considered in changing them for future use. So what happens is measure developers build out a group of synthetic patient test cases to validate that the code for each part of the digital quality measure's logic executes as intended. When all test cases for a measure are run, the goal is to achieve 100% coverage, meaning that all components of the measure code and requirements are included in at least one pass and one fail scenario across the test cases, and 100% passing, meaning that all the test cases execute successfully in alignment with the expected results. Each test case export file contains subfolders, the name of each corresponding to the patient ID or UUID for that test case. It also includes a README file that represents an index of all test cases. As I said, CMS is releasing 4 test decks for CMS 2, CMS 506, CMS 986, and CMS 996 as part of the DQM public comment period. We're hoping to get feedback on the adequacy and usefulness of current test case standards and formats, including whether the test cases sufficiently reflect real-world scenarios, whether the test cases adequately address boundary timing scenarios, and if there's any additional information that CMS should consider posting as a supplement to FHIR test case packages published during future annual FHIR measure releases. The test case index file provides a mapping of the test case UUIDs or patient IDs, which are also the names of the test case, the subfolders, to the corresponding case number, test case grouping, and test case title from MADIE. The test case title, which is the rightmost piece of text in each line on the slide, provides a shorthand description of the condition that is being tested to ensure that the code handles it as expected. However, to gain a better understanding of the purpose of each test case, you can also open the human readable file from the measure package and navigate to the measure group sections to review detailed definitions of population criteria. The test case grouping, which is the section of text immediately following the equal sign, is a combination of the measure component of population criterion to be tested and the expected test case result, which will be either pass or fail. For any given FHIR test case folder, you would open the test case JSON file stored inside and search for the measure report resource within the JSON file text. You look for the tested measure components, the population criterion in that section of the text, and make note of population count results. For more details on the utilization of these files, we have hosted, as part of the public comment, a guide for reading DQM test cases, which will be included as part of the language in the JIRA issue when you look to review the content and then comment. Worth particular note within the public comment are the CMS and CDC and HSN hypoglycemia measures. CMS and CDC are currently working together to modernize hospital quality measures through FHIR, and this is beginning with hypoglycemia. As CMS began converting its hypoglycemia ECQM to the FHIR standard, along with all its other ECQMs, CDC was also developing in parallel the NHSN hypoglycemia digital quality measure, the first of many DQMs anticipated for the NHSN surveillance program in the near future. CMS and CDC recognize an opportunity to collaborate and consider possible reporting avenues that would permit automated reporting of a single set of data to serve the needs of both programs. At this point, CMS and CDC have 2 hypoglycemia measures that are designed to be aligned. And CMS is considering reporting options to allow hospitals to report some measures using the NHSN FHIR pathway. This option would help providers build their FHIR capability, reduce reporting burden, and advance data and interoperability. Both measures capture data related to an inpatient encounter, anti-diabetic medications, blood glucose during a calendar year period. The CMS version includes specifications to calculate the measure results, where the CDC measure is calculated downstream by NHSN and can be used for surveillance. This slide describes the CMS and CDC NHSN versions of the severe hypoglycemia FHIR quality measures. Both measures apply to inpatient encounters, which also include emergency department and observation encounters ending within 1 hour of inpatient admission. Both measures cover a 1-year effective period and identify severe hypoglycemia events as defined by blood glucose in patients on anti-diabetic medications. Compared to the CMS measure, the CDC and HSN measure uses longer lists of codes to identify blood glucose lab tests and anti-diabetic medications. For the CMS measure, blood glucose tests include 16 laboratory concepts. For the NHSN measure, 84 concepts are included, including CMS's 16. For the CMS measure, anti-diabetic medications include 92 RX norm SCD and generic concepts. For the NHSN measure, all prescribable and non-prescribable anti-diabetic medications and all RX norm term type concepts, including CMS's 92 terms, are incorporated to ensure the broadest capture of anti-diabetic medications possible. For additional details on the NHSN hypoglycemia FHIR digital quality measure and reporting NHSN digital quality measures, you can visit the NHSN digital quality measures resource page and the NHSN DQM implementation guide pages. There you will find guidance for reporting FHIR DQMs to NHSN, including readiness materials and material to optimize reporting. These resources are also available in the ONC JIRA ticket link that we will cover next. It's important to keep in mind that these are 2 separate measures, and we're looking for feedback in this case on the potential utilization of these measures in CMS and in the context of CMS and CDC reporting programs, and where it makes sense to consider using one or both within the context of those, because the goal is to limit the amount of burden in reporting that is placed upon the providers while still meeting the surveillance needs of the NHSN program and the quality reporting needs at CMS. So we're requesting public feedback on the draft digital quality measures for potential use in CMS quality reporting programs. The draft DQM packages are available through ONC JIRA tickets, including 17 hospital inpatient digital quality measures, 4 hospital outpatient digital quality measures, and 49 eligible clinician digital quality measures. Test case exports are provided for some of those measures, 4 in total, and public comments are open from January 21st, 2026 through February 23rd, 2026, and should be submitted directly on the ONC JIRA tickets. You will note that in addition to the measure specifications themselves and the measure packages that are incorporated with those, we've posted a guide for reading DQM test cases to assist you in doing so. We've also incorporated targeted questions document, which identifies specific areas of interest that CMS is requesting feedback on. We'd ask that you take a look at that as you're reviewing the materials and offer us your fulsome feedback on the measures, the presentation of information that we've offered here, and help us ensure that we can provide the best reporting experience possible for our programs.